kind words of introduction.
And speaking again about very important subject actually about the adjuvant cell therapy and type 1, we used to say type 1 diabetes always for insulin. Now Banshi will tell us if anything can be added. Go ahead, please.
Sure. Thank you, sir. So after a fantastic and very lucid talk from Qatar, which he had talked about how type 1 children are to be educated, and as we know that at present the treatment for type 1 it's a basal bolus insulin, multiple daily insulin injection, it's self-monitoring of blood glucose. They can be put on a continuous glucose monitoring and they can be put on advanced therapy like insulin pump on only some of the patients. So my talk is very different that what we can add other than insulin to these patients as an adjuvant therapy for type 1 diabetes. Nothing to declare for this particular talk. We all know the miracle of insulin, and this miracle before 100 years when insulin was discovered, even a child who was given a insulin, which was the first child, Thompson, was given a insulin, and you can see the miracle. Within 1 month, 1.5 months, child had become almost normal. We know that it's a disproportionate medical burden of type 1 diabetes. Rightly said by my friend Abdullah, that we always talk about type 2 diabetes, and as it's a growing epidemic, and our conference is also revolving around type 2 diabetes, and we are forgetting sometimes type 1 diabetes. But if you see the type 1 incidence, the India below the age of 15 years, we have highest number of children in the world. In compared to type 2 diabetes, we are the second highest. I mean, we are very high number of type 1 and type 2 both, but type 1, we are the highest number of type 1 young adults below the age of 20, 2,29,000, which is followed by US and Brazil. This is IDF 2021 data. This is very interesting photograph which was put on a social media by a parent, by a mother of this child, just to say everyone, to survive for a type 1 child, she has to take 1460 shots in a day. And this is just to tell the society that, for a survival of a type 1 child, she has to prick herself for 1460 times minimum and multiple times continuous self-monitoring of blood glucose. Probably she may not be taking insulin through this because she has not removed the cap of it, and you can see she is on continuous glucose monitoring here, and you can also see here probably she is on pump also. But this is just to increase the awareness in the society. The mother of this child has just put this picture on social media just to tell everyone that how type 1 diabetes is like this. Now my topic is not on basic pharmacotherapy. We all know that a type 1 child is absolute insulin deficient and they have to be on lifelong on multiple daily insulin injection. So that's not my talk. My topic is on adjuvant therapy. We know that type 1 children are also having obesity, secondary insulin resistance, and we sometimes call it double diabetes because they have already one pathology which is insulin deficiency. There is a beta cell destruction, there is a autoimmune beta cell destruction. At the same time, they may develop obesity, and secondary to that, they may have insulin resistance too, like they have in type 2 diabetes, and that's the reason how the adjuvant therapy comes in the picture. When you are talking of only one disease, which is type 1, pure insulin deficiency, probably the only treatment will remain with them is insulin only. But when they develop obesity, when they develop some other issue, the adjuvant therapy may come in picture. When we are talking of other than insulin in a type 1 diabetes, it should be efficacious. The second important thing, it should be safe also, because you are giving something other than insulin to a type 1 child. Now, new onset of type 1 diabetes, we normally start these patients with insulin therapy and self-monitoring of blood glucose, and at the same time we educate the children for hypoglycemia and hyperglycemia. This is what the recommended therapy. In an adult also, almost similar type of therapy which we give for the type 1 diabetes, whether they develop in an adult life also. But insulin, which is the only treatment, but you will be surprised to know those patients who are on multiple daily insulin injection, only 20% of them are achieving a tight glycemic control which is less than 7. And this is the across the world the data is. I am not talking of the patients they are put on an insulin pump. I am talking of the patients who are on multiple daily insulin injection. I am talking of the patients who are doing self-monitoring of blood glucose, and there are patients who are not doing SMBG very regularly. Even the countries like Qatar, who is very developed country or rich country, they can afford for each and every type 1 of their child to give them a continuous glucose monitoring and pump, but still the average A1C of these children is above 8 or 8.5. So it's really difficult for them to achieve a tight glycemic control. The other challenge for type 1 is a glycemic variability. If you do their continuous glucose monitoring because of their diet, because of their stress, because of multiple hormonal reasons, they may have glycemic variability which more happens at the adolescence, and insulin alone may not achieve a tight glycemic control because sometimes they develop a lot of weight gain if their eating habits is not matching with their, the diet control is not good. They may try to take more correction dose of insulin by monitoring the sugar on continuous glucose monitor. They may become obese type 1 and they may develop secondary insulin resistance. So there are different therapies which we are giving for type 2 diabetes. Can the same therapy can be used for type 1, and that's what we call adjuvant therapy for type 1 diabetes. Most of these type 1 diabetes therapy is not advised by any US FDA or European agency or any guideline also. So if you go by any guidelines, none of these have approved. But yes, the European Medical Association, recently they talked about SGLT2 inhibitor, DAPA and sotagliflozin can be used in off-label practice using the GLP-1, but US had already used amylin, analog, pramintide is approved for adjuvant therapy for type 1 children also. So an ideal type 1 adjuvant treatment for type 1 diabetes is to improve the A1C without causing hypoglycemia. It should help for them for a weight loss and reducing the complication for early as well as late onset diabetes complication. This is one paper which is talking of using adjuvant pharmacotherapy in treatment of type 1. I have taken my maximum slide from this. Glucose lowering therapy beyond insulin in type 1 diabetes, a narrative review, and then metabolic control in type 1 diabetes. It's the adjuvant therapy is way forward. These are the different therapies which we can use. Now, in our clinical practice, we had used, some of us had used GLP analog. In India, we don't have amylin analog which is available. So some of the type 1 obese children, we had used GLP-1 analog. This is very commonly used molecule in our clinical practice, which is alpha glucosidase inhibitor, that is AGI, which we use glucobay or acarbose, very commonly used because we Asians eat lot of carbs. I am seeing here also in Egypt, similarly in India, Pakistan, Bangladesh, what we eat is only carbs, carbs, carbs. And even if the correction dose given them by insulin, sometimes the glycemic variability is very, very high, and alpha glucosidase inhibitor is a commonly used adjuvant therapy in type 1 diabetes. Some of our friends which we had seen the DPP-4, but DPP-4 is not very effective adjuvant therapy for type 1. Instead of that, GLP-1 will be real effective for those who are obese type 1 children. But what we can give other than that is a SGLT2 inhibitor, and now there are data for dapagliflozin as well as sotagliflozin. Both the data are there for treating type 1 diabetes. So other option for these patients which we had used also the SGLT2 inhibitor. Now these many clinical trials had happened in a different from 1950 to 2015. If I see, even from the metformin, people have tried even glibenclamide also in type 1 diabetes. People have tried glitazones, people have tried AGIs, people have tried GLP-1, DPP-4 and SGLT2. So at present, if you ask me, metformin for some of the adolescent type 1 who are developing PCOS or secondary insulin resistance, alpha glucosidase inhibitor is a commonly used adjuvant therapy. GLP-1 in a very obese type 1 or amylin analogs can be given, and these number of medications, but out of them DAPA and SOTA have more data to use in type 1 diabetes patient as an adjuvant therapy. Now metformin, as I told you, it can be used as an insulin sensitizer for type 1 diabetic patients, but it is used only in adolescent age or with the PCOS or with the secondary insulin resistance. Where we are using metformin, it reduces slightly insulin requirement, and at the same time there is some weight loss is being also seen with the patients without increasing the risk of hypoglycemia. GLP-1, as I told you, it's a very interesting molecule which we are using as an adjuvant therapy for obese type 1 children, and not children, with the young adults more often. It inhibits the gastric emptying, that's very important, inhibiting gastric emptying. It suppresses postprandial glucagon secretion, it improves glucose stimulated insulin secretion, that will not work. So only one of the mechanism of action will not work here, but other the central effect and the gastric emptying, that local effect will be very effective, and the GLP-1 is found to, in obese type 1, not only decreases the glucose and glycemic variability, but it also decreases the significant weight too. Then type 1 diabetes, GLP receptor agonists have shown to reduce the weight and reduce the insulin requirement. The weight reduction was seen almost 2.2 to 6.6%. The insulin requirement was also significantly reduced. Patients should be vigilant in monitoring and adjusting the insulin dose to reduce the risk of hypoglycemia. And most caregiver also proactively inform patient the risk of nausea and other GI side effects. So sometimes these GI side effects must not get confused with the patient who is developing diabetic ketoacidosis too. There are some clinical trials with DPP-4 inhibitors too. DPP-4 inhibitors found to be in one of the adjuvant therapy, but in my clinical practice I had never used it. They are very weak in their effects to provide clinically meaningful glycemic improvements and may therefore hardly be considered to have any place in treatment of type 1 diabetes. So DPP-4, there are some clinical trials and papers which have been published, but none of the agency, none of the guidelines is recommending, and in my clinical practice I had never used it also. The SGLT2 inhibitor, we know the mechanism of action of increasing the glycosuria. They reduce the reabsorption, the glucose reabsorption from the renal system. The mechanism is independent of insulin, so it is not going to have any effect on the beta cells. Like similarly, the alpha glucosidase inhibitor, the SGLT2 inhibitor has to have effect in type 1 diabetes also. Recently, European Medical Association approved dapagliflozin and dual SGLT2 1 and SGLT1 inhibitor sotagliflozin both as an insulin adjuvant for the treatment of type 1 diabetes. But remember, it is for BMI of more than 27. So it is not for BMI of those children or young adults who are BMI of more than, less than 27. It should not be used because there is a risk of developing diabetic ketoacidosis. When you start using SGLT2 inhibitor, your basal insulin requirement significantly goes down. If it goes down less than 0.2 unit per kg body weight, make sure that now you are not, either you reduce the dose of SGLT2 or you stop it using, because the risk of diabetic ketoacidosis increases very, very significantly. Some of clinicians I have seen they had used even in type 1 who are not very obese, between 23 to 27 also BMI, but then the risk of diabetic ketoacidosis become very, very high, and they should be very cautious to use it, particularly when the requirement of insulin is not very high. So we use SGLT2 inhibitor when requirement is high, child is increasing in weight, there is a lot of glycemic variability, and particularly the child or the young adult who is BMI is more than 27. There are several aspects. One of the biggest risks is always diabetic ketoacidosis. Make sure that decay should not get precipitated because of SGLT2 inhibitor. We know that mechanism, it can lead to decay because of hyperglucogonemia, promotes ketogenesis, it reduces ketone body clearance, it volume depletion, and there is a glycosuria which lowers plasma glucose leading to lowering of insulin dose. So these are the mechanism why a child or a type 1 diabetic young adult can develop diabetic ketoacidosis because of SGLT2 inhibitor. The therapy for, if they have developed SGLT2 inhibitor induced diabetic ketoacidosis, first and foremost is stop drug. That's very, very important. Injection, blood, bolus insulin, give carbohydrate because that require carbohydrate also, hydration, and recheck ketone every 3 to 4 hours. So stop decay protocol is there from 2019 after the clinical trial of sotagliflozin and dapagliflozin in type 1 diabetes. Amylin mimetics is there. It is already approved by USA. It is not available in many Asian countries. In our country, it is also not available. We do use other GLP-1 analog, but the primarily the action of it for the overweight type 1 children, and there is a weight reduction of around 1.8 to 2.5 kg with reduction of insulin requirement for these patients. The efficacy and safety data of non-insulin based add-on therapies to insulin in type 1 diabetes. If I put all these medication here and if I put all these the benefits or the side effects for these, the HbA1c reduction is not very important. What is more important is the side effect profile of all these molecules. That is number one. And the second is we don't want them to have diabetes ketoacidosis, because for SGLT2 inhibitor, it's very effective to reduce the insulin requirement. It's very effective to control even the hyperglycemia, but the diabetic ketoacidosis risk is very, very high with this, so be cautious for that. And the risk of hypoglycemia, if you achieve a very tight glycemic control by adding the adjuvant therapy, then the risk of hypoglycemia also increases, like putting the patient on GLP-1, we may be obese type 1, and then increases the risk of hypoglycemia. So correct. It's the last slide. An exception may be GLP agonist in obese people. GLP agonist and metformin probably, possibly also confirm the non-glycemic treatment benefit, which is the obesity reduction, the weight reduction. And the very important is the SGLT2 inhibitor, DAPA and sotagliflozin, which has been approved by European Medical Agency, can be used for these patients. These are these different type of molecules which we can use as an adjuvant therapy. The meta-analysis tells very clearly that use metformin, GLP-1 and SGLT2 inhibitor, and that too also use in a very individualized case. Don't make it as a part of a statement or a guideline by any association. There is one more interesting paper which had come from a camel milk. So this is also some of the data from India, from Bikaner, some data from other parts of the world also, that camel milk can be used as an adjuvant therapy for treatment of type 1 diabetes. I am sure some of you must have heard, and some papers are there, but in the clinical trials of these different, they had shown some benefit in type 1 as well as in type 2 diabetes, but there is no recommendation, and it is not recommended by any medical association, neither by any doctor to talk for a clinical practice to use it. To take home message is GLP-1 and metformin can be used along with SGLT2 inhibitor, particularly in obese type 1, since these drugs act independent of insulin, so they can be used as a part of type 1 diabetes as an adjuvant therapy. Adjunct glucose lowering agent bear the potential to beneficially impact on a cardiovascular risk factor when investigated in type 1 diabetes population, are suggested to be more extensively considered as a potentially disease modifying drugs in future, and should be investigated for the hard cardiovascular endpoints. However, they should be used judiciously in select patients to mitigate the risk of diabetic ketoacidosis. With this, I end, but few statistics for type 1 we can't change. We can't change a type 1 to have less than 4 injections a day. We can't change them to monitor their glucose less than 5, 7 times, 6 times, 1 times in a day. These are the factors which are responsible for them to develop a lot of glycemic variability. But what is more important is our role begins as a friend, as a coach, as a personal healthcare professional, as a friend or coach who supports these children, who has to play. And we are just like a coach who gives them guidance to play their life perfectly with the type 1 diabetes, living with type 1 diabetes, and taking their insulin regularly and taking their control of the diabetes. With this, I once again thank you DSG and Meshba and everyone here for inviting me and sparing your valuable time with this meeting. Thank you very much.